candidate who attempted.
Yeah, first let me
I'm one of,
congratulate you.
yeah.
Let me congratulate you
Okay.
for passing years. And now you can start, yeah.
All right, thank you, Rata. So I'm Masayu, one of the candidate who attempted exam last October on the second day in Malaysia. It was in hospital Selayang. So I personally think this was a very tough exam, and I think it's required a lot of sacrifice. And on the second day, there were only 4 out of the 20 plus candidate who make it through. And I only passed by the grace and bounty of Allah. So I personally would like to thank this opportunity to Dr. Muhammadi for her dedication, support, and continuous effort to guide me through this MRCPCH journey. So I think I'll start with my STEM. I have 4 clinical sessions at first. It followed by the history, comms, video, and development. My first session was the CNS. It was a 5-year-old boy, and she asked me to examine the neuro lower limb examination. Honestly, I was quite panicked because we actually started earlier than it was supposed to be. When I opened up the door, there were 3 examiners inside. 1 new examiner and 2 senior examiners, all from the Malaysia. And the child actually was sitting on the stroller. I asked the mom whether the child can walk or stand, but the mom said that he can momentarily stand for a few minutes and he only can sit up. So she immediately put the child lying on the bed. I actually wanted to see whether the child has any specific posture on standing position, but because the child already lying on bed, so I just observe for anything, any signs in the lie position. So actually, Shad has generous muscle wasting on bilateral lower limb. I proceed with the tone and proceed with the power assessment, but it was a bit difficult because child has limitation in understanding. He was not able to obey command as well. He was hyperreflexic, hypertonia with contracture, bilateral Achilles tendon. He also has a scissoring posture. Actually, I finished quite early because I could not proceed with properly with the power. So I offered to examine the upper limb, but the examiner actually doesn't allow me to. So I quickly observed the back if there's any VP shunt and spina bifida, but everything was normal. So she kept asking me what else you want to check. So I think she's a bit hesitant to let me proceed with the presentation. So I go back to the lower limb, assess the sensory proprioception, and obviously the child not able to understand the instruction. It was not helpful as well. So overall, I think I give a correct diagnosis. It was a upper motor neuron lesion, and I give a cerebral palsy, and we talk also about the possible etiology such as antenatal, neonatal, postnatal insult, any vascular malformation, brain infection, or malignancy. And she asked about the investigation. I said that MRI, IEM workout, EEG if the patient has seizure, and we managed to go into management. Basically, the management was overall supportive. I gave a baclofen Botox injection and tender release, and OT or for orthotics as well. So time ran out that time. So I think we able to finish up until the management. She commented that the technique a bit rush and lack of structure as well. And child not able to obey some command because of the age and disability. That was my first session.
Okay, any questions, guys? All right, let's go to the next one.
Okay, for the second session, it was a CBS. It's a 14-year-old boy. There were 2 examiners inside, 1 new examiner and 1 Indian examiner from UK. And the child was sitting up on the bed. He has some intellectual disability and dysmorphic as well. I actually started with general inspection because I saw he was a bit dysmorphic. So I asked him to open up and remove the shirt because I want to actually observe if there's any all the signs of the dysmorphism or the child in distress, any sign of heart failure as well. And then I proceed with the peripheral sign. I actually not confidently able to tell whether the child has finger clubbing or not, because the child has a hyperconvex nail. He was not sinus. I quickly checked for the radial and radial femoral pulse. There were linear scar as well, over suprasternal, and 1 cm scar on the right femoral region. The apex bead was not displaced. The child was not in failure as well. There were ejection systolic murmur, grade 3/6 over left upper sternal edge. There was no trill. I think overall the examiner was unprofessional enough. There was a lot of interruption. She was very fierce. She making faces as well. I think at the last minute, the UK examiner took over the exam, but I think it was too late as well. So when I just began to present the case, she was very fierce and scolded me. She asked me to only present the positive finding when I actually wanted to give her only the positive finding. So I missed few points. I missed to mention the scars, I think, because there's a lot of interaction. So I think she actually seems upset when I asked the child remove the shirt too early. She commented that I removed the shirt too early in the feedback. So actually, I did check for the radiofemoral delay and presented there was no radiofemoral delay, but and I can clearly remember that I saw the scar, but they commented that I didn't check radiofemoral delay yet, concluded there was no radiofemoral delay. I think they actually stand behind me during the examination. Probably they not able to see when I perform the femoral inspection. They commented that I missed the clubbing as well. Actually, my diagnosis was correct. It was a Noonan syndrome with pulmonary stenosis, but actually, the child has mild clubbing. It was untreated pulmonary stenosis. They asked a question, what possible cause of the failure to thrive in this child. So I answered them parts of the Noonan syndrome. They have faltering growth, short stature, and the cardiac lesion, pulmonary stenosis itself. And probably after some surgical intervention, they can have pulmonary regurgitation that can cause right-sided heart failure. But they keep asking what else and not allow me to proceed with D2 and investigation and management. So I think I lost a mark at D2 as well. So actually the answer that they want to hear was the pulmonary hypertension and untreated PS that causes failure to thrive in this child. And that was my second case.
Pulmonary hypertension doesn't happen in PS. This is the weird part. Was it a top or something that was repaired?
No, it's actually written in the feedback. It's Noonan with PS, untreated PS. Then she want to hear failure to thrive. She want to she actually commented that causes of failure to thrive is pulmonary hypertension with PS, untreated PS.
But that doesn't make sense, does it?
Yeah.
PS does not have a pulmonary hypertension. And what was the scar mark, by the way?
I'm not really sure. She didn't mention in the feedback. I think probably it's hypothyroid thyroidectomy. I'm not really sure.
So they didn't mention anything about the thyroid possible that could also, this is what I thought was the cause of the short stature, that he had a thyroidectomy or something. Because
they didn't mention that.
Yeah, that's
they
weird.
only mention about the untreated PS and pulmonary hypertension as the causes of failure to thrive.
Okay, we need to ask a cardiologist, how can we get pulmonary hypertension and an untreated PS? I mean, it doesn't make sense, right? It's a protection against pulmonary hypertension. Unless the child has a complex congenital heart disease with some other like associated cause. But what is the cause of pulmonary hypertension? I mean, did he have a loud P2?
Because the mama is quite loud, so I not really appreciate the loud P2.
Okay, all right. Any questions, guys? Okay, next.
Next was third clinical. I get MSK. If it's a 15 years old girl, this time was finger swelling since birth. Please proceed with the upper limb examination. So actually, I proceeded with PGAS of upper limb. I thought it was a disaster because I'm not really sure what was the diagnosis. But actually, I think I get a quite good mark in this session. So I proceeded with PGAS upper limb examination. She had a swelling over the right middle finger and also left index finger. It was not tender, not inflamed. It was liquidy and squashy like fluid inside. So I offer the diagnosis of cystic lesion, and other differential can be dactylitis or septic arthritis, but it was a bit unlikely because there was no sign of inflammation. And she asked about what possible anatomy did I think inside. I said that it was fluid, and or it can be a subcutaneous tissue as well. So I offer investigation is ultrasound or needle aspiration. It's actually she is looking for a transillumination test. So it's a case of 15 years old Turner syndrome with lymphangioma. Oh, I forgot to mention that she has a Turner features, this child. So it's case of Turner syndrome with lymphangioma.
Yeah, an atypical case. But they do give these kind of cases in MSK. All right.
Yeah.
So in the management, what did you say for the child?
We didn't proceed with the management. It's just up to until investigation.
Okay. Okay. What was next?
Next, the fourth clinical was respi station. It was a 9 years old girl. She was not dysmorphic. She was sitting up, and the most striking things that I saw was depressed right chest. She also has a reduced chest expansion on the right side. There was no obvious scar, no clubbing. She's being not in distress, and it's a bit difficult to feel for the apex bit. I even tried to locate 3 times. No added sign on auscultation as well. So actually, I thought it was a right lung hypoplasia. I give my findings that she has a displaced appendix, reduced breath sound, vocal resonance on the right side, and my differential was right lung hypoplasia, CAM, lung collapse post infections, and actually it was a wrong findings and also wrong differential diagnosis. Diagnosis was bronchiolitis obliterans. She actually asked about the investigation. I gave a HRCT, and we did not manage to get into management as well. So I think overall it was I thought it was a good station, but it turns out it's not.
Yeah, sometimes you think the MSK was really bad, but you got good marks in that, and vice versa. Okay.
Yeah. Then the fifth one is history. It's I think a 4 months old baby with sudden onset of irritability. And while changing diapers, mother noticed that he has bruises on the right thigh and swelling as well. There are also some bruises with different ages and colors over the face as well. And the station required a lot of open-ended question to have her to open up that she actually was separated from the husband 6 months ago. And mother is not working. The grandmother was the sole breadwinner since after she separated. And if she needed to go somewhere urgently, she need to give the children to the neighbors to be taken care of. So actually the neighbors, it was a young gentleman, a technician, and the thigh swelling and irritability occurred after she was under the neighbor's care for a few hours. And I asked about if the neighbors has aggressive behavior, any drug abuse, alcoholic, and she denied. So I give the diagnosis of NAI, and the examiner actually want only 2 diagnoses. So I said it was either non-accidental injury or it's accidental injury with right thigh fracture. So I gave investigation, CT brains, character survey, eye assessment to look for retinal hemorrhage, and baseline investigation like coagulation profile, full blood count to look for thrombocytopenia. And we goes into management. I would like to lodge a police report and to involve social worker as well, auto team, I team. And I think we finished quite early. She said she had no more question to ask, and I get full marks in this session. So I think overall it was smooth.
Okay. Yeah, we discussed this last time as well. All right.
Yeah. Mm. And then the sixth station was comms. It was a dengue pathophysiology. You need to talk to junior medical officer, Dr. Helen. She was very anxious. She managing a dengue case with a patient with total weight of 4.5, hematocrit of 37, HB of 11.5, and platelet of 24. She actually wanted to transfuse platelet. She even already take the transfusion consent, fill up the blood transfusion form, and she just meet me for asking for second opinion. I asked about her understanding and how many dengue cases that she had managed so far. She said that she has not many experience in dengue case. It's around 2 to 3 cases that she managed so far. So I explained a bit about the dengue pathophysiology, that the virus itself will directly invade the bone marrow that cause transient bone marrow suppression, and usually the platelet will recover after the infection. And also talk about the peripheral platelet destruction and third space loss in the second stage in the critical phase of dengue. And I also told her that many research showed that there's no evidence of platelet transfusion that will help out with the platelet recovery. Instead, it will cause a delay in platelet recovery. So she asked that do we need to wait until patient bleed, then only we consider to transfuse? And then she kept worry about the bleeding. So I said to her that you need to correlate clinically, and we need to assess other biochemical parameters, not only platelet alone. So you need to observe if there's any occult bleeding signs such as mucocutaneous, gum, nosebleeds, GI bleed. And you need to see whether the hematocrit HB on the lower side and lactate will be high, climb up as well if patient has some bleeding. So, and then I said that as per protocol in managing hemorrhagic dengue, the first line of treatment will be whole fresh blood, not platelet. And I advise her to monitor and keep an eye on the patient full blood counts and monitor the fluid intake as well, and suggest to give appointment to see platelet recovery when patient able to be discharged. So I get full marks in this station.
Okay, and I think she was anxious because a previous patient died or something, right?
Yeah, actually she didn't mention that to me, but I said to her that I know that you are very worried because there's in some cases patient can have a severe hemorrhagic dengue and patient might succumb. Then I explained. Yeah.
Okay, so what was next?
Next was comms as well. It's a 2 years old with type 1 DM. It was diagnosed 2 months ago. Came with hypoglycemic attack. I think this time was very, very long. It takes time to digest. The child glucometer was 1.2. I think he presented with seizure or syncope, cannot remember. And mom did not regularly monitor the blood sugar at home. For the last 2 weeks, she had noticing that the child has some irritability and always tantrum, and mom not able to recognize that was some hypoglycemic symptom. The task was to explain hypoglycemia treatment to the mom. So I think the role player talk a lot. Most of the time, I need to just listen to her. And for the last few minutes, I take some time to explain to her about the hypoglycemia symptom and emphasize the importance to frequently monitor the blood sugar so that during the follow-up, we can decide whether we need to adjust the dose of insulin. And I said to her that I will consult my endocrinologist as well, because I think we need to reduce the insulin dose at this point of time. So I educate her about the hypoglycemia treatment as well. I provide her emergency number and advise her to wear bracelet to refer dietitian as well to teach about the calorie insulin conversion, meal plan, and educate on the sick day and to see diabetic as well. I think overall it was smooth. She cut 1 mark because I did not mention about the honeymoon period. I think she looking after the honeymoon period. But overall, I mentioned about the needed for insulin adjustment. That was the
Okay, and
second
the
comment.
management of the hypoglycemia. how much did you mention? Up till the glucagon, or just give the child
For
some
for the hypoglycemia, actually, I just mentioned that she need to take half of the uh, half box of the juice, or she can put a 3 spoon of the sugar inside one glass and took half of it. I didn't mention about the glucagon or glucogel because as far as I recall, when I discussed with my endocrinologist, we don't have that in Malaysia, so I didn't offer her that.
Okay, all right. So
Next was a video session. It was a Bell's palsy. I think it was a clear video that the child has lower motor neuron facial nerve palsy. It was smooth. He asked about level of lesion affected, and I said that it was a below Pons level. So I get a full marks on this.
Okay.
And the second video was about left pleural effusion. The video showed that patient has underwent respiratory examination. The auscultation showed she has a reduced breath sound, reduced vocal resonance, and dullness on percussion on the left side. I think
So in the rest of the examination, I just want to make this clear. Everything is being done right in the video from
yes,
inspection.
yes.
So
It's only at the back.
only at the
Inspection,
back.
chest expansion, auscultation, vocal resonance, as well as percussion at the back.
Okay, so the full respiratory examination, because
Yes.
one feedback it was written that you didn't do the complete respiratory examination. So what did you mention in the additional examination?
I said that I would like to proceed with the, I want to see whether the child has clubbing, BCG scars, trachea deviation, and then as well as ENT examination. I think as well as the apex bit. As far as I can remember, I'm not, not
They
really.
didn't write in the comment. Yeah, I mean, you didn't get any marks cut in this one, right?
Actually, she cut me 1 mark because she said that I didn't consider other differential diagnosis. I actually gave pneumonia with parapneumonia effusion or pleural effusion and pneumothorax, post-infectious, especially PTB in our local setting with lung collapse. I think maybe she wanted to hear like chylothorax, fluid overload, or congestive heart failure, something like that.
Yeah, but the examination was fine according to her. So because she commented in the other candidates that they didn't complete. I mean, if they've done everything, what is the extra stuff? Maybe they wanted more, because they should be writing exactly what they wanted, right? Rather than simply saying you did an incomplete respiratory examination. What does that mean?
I'm
Now let's see. Yeah. Okay. So next.
My last station was development. It was a 2 years old girl. She was taken care by auntie. Actually, auntie stopped working recently to focus on her. Both parents working away, and she had concern about her development. The task was to assess fine and gross motor domain. Actually, the child has an infantile spasm at the age of 3 months old. Initially, she was started on treatment. Somehow, the medication was stopped at the age of 16 months old. And since then, the seizure became uncontrolled. Now she needed 2 anti-seizure medication. And the speech and social aspect of the child was around 3 to 6 months old. As far as I can recall, she only able to vocalizing and then turn to sound. I think the eye just fixed and follow on the 90 degree. And otherwise, she had a lot of other issue like swallowing and coordination. She was only on bottle feeding and not started on weaning. There's a lot of things to ask. I think I could not finish in time, but managed to go a little bit into the social part. It was a non-related parent, no significant family history as well. And for the assessment, for the fine motor and gross motor examination, it revealed that the child has 3 to 6 months developmental age. As she can only, she had a palmar grasp and it was not consistent as well. The gross motor, she has no head leg, but she sit with rounded back. Otherwise, there's no dysmorphic. The growth parameter was okay. No positive of movement, no abnormal posture as well, no surrounding aids. So the discussion on the differential diagnosis was infantile spasm, epileptic encephalopathy, Lennox Gastaut, and IEM. So I gave investigation like MRI, EEG, vision hearing assessment, and IEM. And the management was multidisciplinary team approach, neuro to consider ketogenic diet because the child already onto anti-seizure medication and seizure still not well controlled. And other things was supportive treatment like occupational therapy, physio, speech, swallowing assessment, parental training support group. I think it was smooth. She cut me only 1 mark. She commented that I'm a bit hesitant in getting history. I'm not really sure what she meant because I think it takes time that because there's a lot of things needed to ask for this child. So overall, it was smooth.
Yeah, I think you did it well. You asked about all the problems of a CP child, and
Yeah.
the child now has another type of seizure, right? Before it was infantile spasm, and now he's got another type of seizure. When did that start?
Yeah, there's another type of seizure. I could not remember exactly. Initially she has generalized seizure, and then I think it became a focal seizure
Probably
afterward.
after 16 months because the medication was stopped at 16 months. So now
Yeah.
she's 24 months, around 8 months gap, right? So it's
Yeah.
somewhere in between. And now, like the child is having regression after the infantile spasm, or is it like the.
I think she never had regression. It was the child has development was not progress.
Oh, okay, developmental delay because some
Yeah.
people also get regression as well. That's why. Anyhow, it depends on the role player, what history they give you. Sometimes they change it and stuff. Yeah.
Yeah.
So this is interesting, a very complicated case. I mean, they're giving you the infantile milestones.
Yes, it's a bit difficult because we actually rarely practice on the less than 2 years developmental age.
Yeah, we have to focus on all the ages, birth onwards, for the development. Anyhow, okay. So next,
I finished all the 10 station actually.
oh, that's good. That's great. You finished feedback fast. Any questions, guys?
Can I ask regarding
Maybe
the
like, yeah.
development question? The infantile spasm was the diagnosis that we need to give in the end of the in the end of the discussion, or is it an underlying condition that had been known?
Yeah. Did she?
No, actually, I gave the diagnosis. It's the mother did not give the diagnosis.
So what did she say to describe the infantile spasm?
She said that she has some like spasm like movements. She said like that.
Oh, okay. So she didn't say the name. Okay.
No, she didn't say the name.
Mm. That's good because everybody diagnosed it. I mean, all my candidates, they gave the feedback infantile spasm without any hesitation. So this is the first time I'm hearing it that and the mother never said it. I was thinking maybe the mother said it. I mean, the aunt. Anyhow.
She said a spasm like movements. She never said about infantile spasm.
And any family history or anything significant in the birth
No.
or no,
It
nothing.
was no. There was no family history with similar symptoms. Parents also
Mm.
non-related parents. The family history was not significant.
So what
There
did you
was
give
no
for the
birthmark as well.
Ah, yeah. So it's some like a congenital malformation or something congenital, right? Probably.
Yes. Yeah, yeah. So what again? Sorry, doctor. What's your question again?
Yeah, I mean, there's no acquired cause. It's probably something congenital, brain malformation, or as you said, inborn error also could be a possibility. Was there any consanguinity?
No, no. There was no consanguinity.
So did you mention any, genetic testing or anything like that?
I could not remember. I think I said about MRI, EG, vision. during assessment IEM screening.
No, in
I
you mentioned Lennox, gastro, inborn error,
yeah
metabolism, those things you already mentioned. Okay. MRI also you mentioned. So okay, yeah, that's enough. But we can also add genetic testing just to rule out any possible underlying syndrome. It can't be red, of course, because this child had a problem from the beginning, or any, if there's a neuroregression, a female child, we should think about that. But this is like a
mm,
global, delay from the beginning, no
yeah
regression. Okay, then thanks a lot, Masayu. It was a detailed feedback. Though we managed to do it quite fast, I think. Fastest one yet.
okay.
You
I
gave the
yeah
details we needed. It's not like it was fast and short or anything.
okay. Yeah,
Okay.
I actually wanted to thank to Dr. Muhammadi a lot lah, for your support. I've been with you for the past 1 year. You helped me a lot to go through this exam. I think personally, I am a person with zero experience and knowledge about the exam, about the structure, the flow, exam flow. So it takes me around 6 months, 1 to 1 year to prepare for the exam. And I think I've been with you for the last 1 year. It was one of my friend who introduced me to this course, and I think this course helped me a lot to understand the exam concept and flow. I also made a
And
lot of friends from the MK group as well.
yeah, exactly. You guys
Mm.
find a lot of Malaysians in the course as
Mm.
well. So it's helpful.
You
And that's
need
what,
we really need a lot of practice, so and a
yeah.
dedicated team of friends to practice with. So that's helpful as well with the practice.
Yes. Well, I'm really happy you passed. It was a tough exam, especially day two. And I mean, as I say, we should always thank God.
Yeah.
Yeah, no matter how much effort we do, nothing can happen without Him. So that's the main thing. Well, thanks a lot. I'll stop the recording now.
All right.